This is the International Academy for Clinical Hematology around the globe and across the hematology field. I'm Mohamad Mohty from the Sorbonne University and Saint Antoine Hospital in Paris, in France. A very warm welcome to all of you joining us today for this IACH special webinar dedicated to the most recent data and results that were presented at the last EBMT annual meeting that was held in Glasgow in the United Kingdom last week. And that was actually a special EBMT annual meeting because we were celebrating the 50th anniversary. EBMT was founded in 1974, and this society, this organization, has contributed a significant amount of knowledge and data to advance the field of stem cell transplantation. And like every year, the IACH is very proud to organize these special webinars dedicated to different post-congresses activities, whether ASH, EHA, EBMT, like today. And in order to give you the highlights and comment on the data presented at EBMT 2024, it is my great pleasure to welcome with me Professor Zina Peric from Croatia, and she is the current chairwoman of the Complications Working Party of the EBMT. Zina, welcome. I have the privilege to have also with me Professor Arnon Nagler, who is the past chairman of the Acute Leukemia Working Party of the EBMT, very active contributor to EBMT since 40 years. And actually, during this EBMT in Glasgow, he was honored by the honorary membership. So congratulations, Arnon.
Thank you so much.
I have also with me today Professor Ali Bazarbachi from the American University of Beirut Medical Center in Lebanon. He is also another a very active contributor of the EBMT, and he was elected during this annual meeting as the new lymphoma working party chairman in the EBMT. I have also with me Professor Florent Malard, who is the current secretary of the Cellular Therapy and Immune Biology Working Party of the EBMT. And last but not least, I have Professor Bipin Savani from Nashville, another big fan, contributor, and well-wisher of EBMT, although he is based in the US, but he has been a subcommittee leader of the Acute Leukemia Working Party since many years, and he is the co-editor-in-chief of the journal BMT, which is the official journal of the EBMT. So this annual meeting in Glasgow has been really a fantastic celebration. I hope, guys, you agree with me. Although the weather was a bit cloudy and rainy, but anyway, we were not there for sightseeing. We were there for work. We were able to enjoy the warm hospitality of our Scottish and British colleagues, and I think everybody has enjoyed it. As usual, you can post your questions, send your comments, and I'll do my best to moderate all this and share this with the panelists. I also know, and I do apologize because we didn't take it into account, it is a holiday in some countries, but hopefully you will enjoy the content of this post EBMT brought to you by the IACH. So without any further ado, my first question to each member of the panel today is about, just in a couple of words or sentences, what is your take-home message, your one study highlight of EBMT 2024? And of course, ladies first. I'll start with Zina. Then I'll take it by alphabetical order.
Thank you. It's great pleasure to be with all of you discussing EBMT highlights, and thank you, Mohamad, and to IACH for the invitation. Well, as usual, my highlights are around GVHD because this is my main clinical interest, and also in the transplant complications working party. So. Well, I don't know. I think it's not anymore new, but I'm very much still fascinated about the role of microbiota in acute GVHD, in GI GVHD. I think Dr. Malard, Florent, he showed very nice data of the compassionate use program of the MAT study. So maybe he can elaborate about it more. I think everybody have seen those really nice data. This is especially, I mean, great data in ruxolitinib refractory patients. So I think for acute GVHD, I would maybe highlight this. Also in steroid refractory chronic GVHD, we've seen some long-term data on belumosudil. We've seen some fascinating data also for fibrotic forms of GVHD with axalitimab, and well, we have even seen some interesting data of moving ruxolitinib to prophylaxis of GVHD. There was a randomized study by the St. Petersburg group also, which showed some non-inferior prophylactic, let's say, use of ruxolitinib, which so let's see a calcineurin inhibitor-free approach for prophylaxis. So this is really, the field is definitely changing for GVHD. So it has become really interesting. But I think we'll probably elaborate about it a bit more. So I should leave others to highlight their yeah.
Absolutely, and I do agree with you that I think now in the last couple of years we've seen some incredible advances in GVHD, and whether acute or chronic, and this has been stagnating now for many years. So now I said I'll go by alphabetical order. So now, Ali, what is your highlight of this 50th annual meeting of the EBMT?
Thank you, Mohamad. Good evening, everybody, and would like to thank IACH and Dr. Mohamad Mohty for organizing this webinar and for the invitation. So in the lymphoma field, I think that the highlight is the EBMT activity survey. So when we look to the number of transplants for lymphoma, as well as cellular therapy, we can notice an exponential increase in the number of CAR T cells, increasing from 800 in 2019 to 2,200 in 2022, so almost tripled. And at the same time, this is accompanied by a drastic decrease in the number of allotransplant for non-Hodgkin lymphoma, decreasing from 1,400 to around 900. Well, in these 900, there is one subtype of lymphoma in which the transplant activity continue to increase, which are T-cell lymphoma. So basically, overall, we can say that in B-cell lymphoma, the field is shifting towards cellular therapy, toward CAR T cells. In T-cell lymphoma, transplant, whether auto-transplant or allotransplant, continue to increase. So I think that this activity survey is a main indicator of how the field is moving in lymphomas.
Fantastic.
And
Thank you.
at the same time, one last comment. We also have a decrease in transplant activity for auto and allo transplant for Hodgkin lymphoma, but this time it is good news. This is because of the higher efficacy of first-line therapy. So we are curing more patients in first line, so we have less auto indications, and we are curing more patients in second line, and we have less allo indications.
Thank you, Ali, for this nice summary. I think these are important data, and this piece of information about the evolution of the activity is crucial, I think, to prepare for the future, and hopefully we'll get some CAR T cells directed towards T cell malignancies, and that's going to be a turning point. Florent, what is your highlight?
So yes, thank you, Mohamad. I am very happy to be here and to celebrate the anniversary, the 15th anniversary of this great EBMT. So regarding the highlight, so first I want to thank Zina for highlighting the study I presented. So I will not highlight this study, of course, for an obvious conflict of interest. I would like to highlight one abstract that was presented during the Presidential Symposium regarding the impact of HLA in the PTCy era, because we used to say that now with post-transplant cyclophosphamide, maybe HLA mismatching doesn't matter anymore, and that we can use unrelated donor and mismatch unrelated donor with the same result. And in fact, we have this very beautiful study that were performed by Esteban Bolaños with the CTI-WP that evaluate the impact of HLA mismatch in the PTCy era. And in fact, we have the same finding as previously with the lower overall survival in patients that have 1 or 2 HLA mismatch. Of course, people are still doing better compared to previous prophylaxis, but HLA still matters today, and we still need to evaluate this kind of data.
Thank you very much, Florent, for bringing this. And I guess we're going to speak about post-Cy because there have been many studies there. Arnon, what is your highlight? And you've presented some nice work during the EBMT.
So I would say that, first of all, I agree with my distinguished colleagues. I would just say that for me, EBMT was nice to see how data are maturing and how we have long-term data. So Professor Bazarbachi, they presented some long-term data about AML in elderly patients and with mutation. So I think, and also we had some, more advanced data or long-term data for the anti-GVHD prophylaxis, both for ruxolitinib and also for the actilimab, the anti-CSF1 that was presented first time at ASH. So, I think that maturing data and long-term data are extremely important. The same is true for the haplo. Data are maturing, and now, like many years ago in Hodgkin, after we did the breakthrough, we are talking about toxicity and how to reduce the toxicity in haplo with PTCy. And so a lot of data from PTCy, as we heard, and for haplo. And the last one is dissecting the outcome of leukemia according to the mutation and to the new WHO and ICC classification. So for this is for me the important aspect of the EBMT, the 50th anniversary. And thank you.
Thank you, Arnon. Bipin.
Thank you, Professor Mohty. I'll be quick. So 2 points mainly, and we'll be discussing more later. Number one, rapid dissemination of PTCy-based haploidentical transplant across the globe. And look at the numbers we discussed at the EBMT meeting. And my second most important, I think Professor Bazarbachi already mentioned, declining number of auto and allos in lymphoma, but rapid dissemination of earlier line of therapy, immunotherapy, in Hodgkin's, in B-cell lymphoma, CAR-T and bispecific. And look at the guidelines Gloria from Barcelona presented. Fantastic. Lots of highlighted multiple upfront bispecific and CAR-T with chemotherapy and combination of all three as a frontline therapy in high-risk non-Hodgkin's lymphoma. We'll be discussing more. Thank you, sir.
Thank you very much. And I think you already gave us a very nice summary. So let's dig a little bit deeper now, and I'll take things just in a logical manner. So there is an indication for transplant, and we heard that indications are changing. In lymphoma, the indications are decreasing. In myeloid malignancies, we still have some decent activity, and obviously it's more about the high risk, the relapse refractory patient. So for all this, we need conditioning. And my question, because you've pioneered a lot of these studies, to you, Arnon, about conditioning highlights, and what are the key messages today when it comes to conditioning regimens, especially, for instance, we've seen now we have seen an increase in the use of treosulfan-based conditioning compared to busulfan. I'll speak in a second about these so-called FLAMSA-like regimens, because there is a recent randomized study, non-inferiority study from our colleagues in Germany, published in Lancet Hematology, about comparing frontline transplant versus induction followed by transplant. So what are your thoughts, Arnon, on the conditioning in a nutshell?
So I think that also from the conditioning, we had more and more studies that look on combinations of the conditioning. You know, we have a study by already Saracini, you know, that compared TBF to treosulfan-based conditioning for haploid identity transplant and show no difference. But we can dissect the conditioning according to the age. So there is a study from Rolly from France that show according to the age, he compared the TBF to the reduced intensity conditioning, and they show again by age that if you are below the age of 60, then you can allow TBF conditioning that will reduce the relapse rate without increasing the non-relapse mortality, and the overall survival and locality of the survival will be the same. But above the age of 60, then the TBF result with higher non-relapse mortality and non-difference in relapse. So you will not want to increase. It also depends on the status of the leukemia. There was a nice presentation by Alexandros Tonionidis about the conditioning intensity that was developed by him and by you, Professor Mohty, the PCI, that now had confirmation. But again, we are now starting to dissect the TCI according to the comorbidity. Many years ago, we showed that we have more infection with treosulfan, more cardiotoxicity with busulfan, and more GI tract with melphalan. And now, I mean, we are starting to look on this TCI in the haploidentical transplant and with PTCY. It's then the PTCY is chemotherapy, so we may want to edit, you know, take it into account when we calculate the conditioning the patient is receiving. You know, also the FLAMSA, there are various combination of FLAMSA, and Thomas showed again difference about the age. So with the conditioning, I think that the component of the conditioning are the same, no new chemotherapy drug or so on, but you know, we are starting to fine-tune the conditioning according to the patient age, the disease status. And as PTCY is getting more and more into, it's already anti-GVHD prophylaxis in 27% of match unrelated and 21% of sibling, that we need to take the PTCY into account when we discuss the intensity of the conditioning.
Excellent. Thank you very much. And indeed, I must confess that I myself presented in one of the oral sessions a talk about the incidence of VOD, showing that post-Psy by itself, high dose, 100 milligram per kilo total dose, is actually adding probably another risk factor for a higher incidence of VOD and more severe VOD, which is quite logical if you add it to the other alkylating agent within the conditioning regimen.
One more thing that I was fascinated was the first talk, I think, in a plenary session about the repertoire of T cells with PTCY, that they look on the clinical study in the state, the 1703, and they found out that the PTCY reduced the repertoire of T cells, and this may be a cause or reasoning for a higher infection rate, and especially viral infection rate with PTCY. So we started in all this conditioning to look into, some toxicity, some ages, and long-term effects, and it's nice. Thank you.
Thank you, Arnon. So it looks like, post-Psy is a key word. That brings me to the GVHD prophylaxis topic. And here I would like to ask you, Florent, what is the standard of care for GVHD prophylaxis today based on what you heard at EBMT? But I would like also to hear from all the other panelists, because probably you may have different opinions.
So yeah, thank you, Mohamad. In fact, we see that the field is moving for GVHD prophylaxis because we have the very well established calcineurin inhibitors plus mycophenolate mofetil or methotrexate combined with ATG that remains the standards for patients with the match-related donors. It was supposed to be also the standard for patients with an unrelated donors, a match or mismatch unrelated donors. Nevertheless, with a very impressive result with the paracetamol cyclophosphamide, now paracetamol cyclophosphamide is more and more used in this setting. But in fact, the result seems to be comparable in these patients. It may be in some very specific subgroup of patients that PTCy may be better than the ATG, but for the broad population, we cannot make any definitive recommendation regarding if we should use ATG or PTCy for those patients. One of the questions is, should we combine ATG plus PTCy and reduce the dose of PTCy, because we have the standard dose of PTCy 50 milligrams for 2 days, day plus 3, day plus 4, but this is associated with some toxicity, with some cardiac events, and it was shown in particular by Dr. Dillery in some previously published paper that lower doses of PTCys at 40 and even 35 milligrams per day for 2 days were associated with the same efficacy, with the same incidence of chronic graft-versus-host. So this is an improved patient's outcome related to decreased toxicity. And we can also combine this platform with the low doses of ATG to be very effective. We are speaking, of course, in patients that receive some peripheral blood stem cells with mismatch-oriented donor or plus or haplo, with some very good results. So we don't have any definitive answer regarding the best prophylaxis. The field is moving. We can use ATG, PTCy, combine them, and we really need to rethink how the doses of PTCy.
Bipin, how is it on the other side of the Atlantic? Because I know that the use of ATG is a little bit more controversial on the other side. What is the current practice?
So, more or less same like Dr. Professor Malard explained, but I'll give you our example also, our institutional, which mimics most of the centers in the United States. So PTCy-based conditioning regimen, PTCy-based GVHD prophylaxis is standard in almost all haploidentical. We don't use IACH, we don't have TO3 or sulfan in most, except in benign condition. For standard match-related donor, match-unrelated donor, we are still with calcineurin inhibitor, mostly tacrolimus with methotrexate or ablative regimen. For reduced intensity regimen, we're still stuck with the tacrolimus and mycophenolate. Nowadays, we have changed recently more practice on match unrelated donor. We have added PTCY based GVHD prophylaxis. Definitely, we switched to PTCY based GVHD prophylaxis for mismatch unrelated donor. So more and more based on recently published randomized data and presented at the IACH plenary session.
Thank you, Bipin. So that brings me, because at the end of the day, we're talking about trying to get rid of those alloreactive T cells responsible for the GVHD, and while optimizing or preserving the graft versus leukemia effect. And that made me think about that we have seen at this EBMT, but also, as you mentioned, at ASH, but also at TCT in February, the advent of novel technologies trying to separate GVL and GVHD. And I'm thinking, for instance, about the Orca Bio technology. So Arnon, what are your thoughts? I know there are ongoing trials, but the results look attractive, that on one hand, we are able, to have a sort of a tailored T cell manipulation and take out what we don't need and just maybe give an add back. What are your thoughts? We need your microphone.
First of all, about the ATG, I fully agree with Malard, because I presented data, the exact 2 arms of the 1703. If we add, although it's not randomized study, so less powerful study in the registry, ATG to the control arm, the results are exactly the same. So no more advantage for the PTCY. And also, we presented data on behalf of acute leukemias that no more relapse with PTCY. So as you stated, for the ORCA, I'm very fascinated, because I mean, they have, if I remember correct, zero mortality, almost zero mortality, less than 10% GVHD, and very low relapse rate. So, and we always call this ex vivo manipulation, boutique medicine. But here we have a platform that they provide to the centers, and I guess that within 2-3 days, the center can have their product and start the transplant. So I think that this is, a dream for me, that you can have such a result, such low GVHD, mortality, and relapse by separating, the GVL from the GVHD with a, manipulation of the graphs. This is fascinating. It's really great data.
Thank you,
Mohamad.
Yes, please.
I can add some data for lymphoma. So, as you know, in the early days of haplotransplant with PTCY, the results of haplo compared favorably to those of matched sibling or unrelated donor, and superior to cord blood, both for non-Hodgkin lymphoma and for even there was in Hodgkin lymphoma a hint that haplo at PTCY was better. Then came the field of using checkpoint inhibitors in Hodgkin lymphoma, which was associated with increased risk of GVHD, but with excellent outcomes. And published data a few years ago showed that the important player is PTCY, regardless of the type of donor. So PTCY with match unrelated donor or with haplo is standard of care when doing an allotransplant after checkpoint inhibitor. Then recent data from the EBMT Lymphoma Working Party, as well as combined CIBMTR and EBMT data, have shown that match unrelated donor with PTCY is indeed superior to haplo with PTCY in non-Hodgkin lymphoma. So I think that PTCY is becoming kind of standard of care in the conditioning of allotransplant for lymphoma.
So we're talking of both definitely a key word. I hear also frequently another key word, haplo. But at the same time, we see also people and trials and companies still investing in cord blood. So I wanted here just to open, like, between brackets, maybe one word about the current status of cord blood, because, for instance, I've seen some data from Excelterra about expansion of cord blood cells and some interesting results. There are also other companies developing this, maybe in non-malignant indications like hemoglobinopathies. Any thought on this? What is the future there? Is it a case closed, or Arnon, maybe you would like to add?
I mean, I think that cord blood has a very unique cells and very unique biology, you know, of the anti-leukemic effect. So there are a lot of NK cells there. There are cytotoxic special cytotoxic CD4 cells, and there are several studies from Seattle and others from UK in pediatrics, and have shown better achievement of MRD negativity and lower relapse rate with cord blood transplantation. So I think that from a biological point of view, this is a very interesting source of stem cells and immunological cells. And of course, the main problem was the ex vivo expansion. But as you mentioned, I think it seems that there are now ways to overcome the slow engraftment, which resulted in a long hospitalization, you know, very expensive transplant, high risk of day 100 mortality, high infection rate. So, I mean, there are several approaches, like one you mentioned and others, that, you know, overcome this problem. And I would say that I would like to see, and I don't believe that this is a dead story, although it's much easier to do transplant with PTCY, but there are also data about the PTCY in cord blood, you know. So for sure, it's still around for pediatric and genetic disease, but I would say that also for adults with hematological malignancy, it's not a dead story. And maybe time, you know, there's some fashion in medicine, so maybe one day it will become attractive.
Thank you, Arnon. Bipin, you wanted to comment on this.
So no, I fully agree with Professor Nagler, and same comment. So, you know, Omidovacil Gambia product, which was approved several years ago in United States, expanded cord blood. For my understanding, utilization is very minimal. Exceltra, more or less similar, that another company, but similar name, I don't forget the name of the product. They still have long way to go to complete the clinical trial. Cord blood utilization without expanded cord blood is almost less than 1% in, I would say, if you look at the registry data nowadays in malignant disorder. Very, very limited indication. Future, I don't know, but it will, despite FDA approval, not been used much, except though where we can find related, unrelated, or adopted person, no donor, which is less than 1% of all population.
Thank you, Bipin. Let's move now to GVHD. And my first question to you, Zina, is about, based on what you heard at EBMT, based on your practice, can you first remind us what is the standard of care in the management of acute GVHD, and then we can discuss the novel things that are coming.
Yes, well, thank you, Mohamad. Well, of course, we are lucky to have the EBMT GVHD guidelines. So everything is, I think, very clear, and it makes our life easier. And for the first line, I think there are, let's say, well enough randomized data to be sure what we are doing in the first line. But of course, and now with the update guidelines and of course the approval of the only agent that we have approved in the steroid refractory ruxolitinib, it's also, let's say, easier to have the, let's say, the clear second line. But then, of course, there is the problem: when do we say that something is ruxolitinib refractory, and can we say before we declare ruxolitinib refractority, can we do something else? These are my main questions. So in the studies, we usually use day 28. We now know that ruxolitinib refractoriness or that ruxolitinib will usually be effective in the first 2 weeks. So basically, I think this is something to work on, to define when do we move on. Should we act a bit faster, also to declare steroid refractoriness a bit faster now with the new agents? So I think this is something to change probably. And also, is it really something ruxolitinib refractory and steroid refractory, or is it steroid dependent and ruxolitinib dependent? And is it different, actually, those two things? I think that what I found interesting in the data from the MAT study, and I think you can probably, Mohamad and also Florent, comment, is the difference that the FMT showed in those patients between steroid dependent and steroid refractory, because I always feel that this difference is due to actually this dysbiosis and tissue repair that can be done in the steroid dependent, or let's say in ruxolitinib dependent GVHD, which can be done with some of those novel approaches as FMT. So and some also basic data have shown that in those steroid, for example, dependent patients, we have complete immunosuppression. There are actually no T cells. But what actually can be improved is this tissue repair thing and dysbiosis. So what it makes me wonder: is it true that sometimes steroids are not completely effective and ruxolitinib is not completely effective? And could we actually improve those agents with adding some of the new agents which can repair tissue and dysbiosis, as FMT, for example, and interleukin-22 and agents like that? So some of those combinations which could actually improve effectivity of the drugs that we have. So this is what I'm wondering.
No, thank you, Zina. So it is clear, and I believe there is a consensus, and this is according to the EBMT guidelines. First-line treatment, corticosteroids. We can argue with 1 milligram versus 2 milligram. And in the classical steroid refractory situation, we'll move to ruxolitinib. So ruxolitinib is well established. But I think, Florent, you alluded to the fact, and maybe it's a good move in my opinion, that we are trying to, and we'll speak later about microbiota modulation. And by the way, the opening lecture during the opening ceremony of this EBMT annual meeting was dedicated to microbiota, and it was a beautiful lecture delivered by Dr. Marcel van den Brink. But here, it looks like that some colleagues are trying to take Ruxo earlier with a rapid intervention, which may not be a bad thing. Florent, can you just give us a few hints about what you saw?
Yes, so this is a question if we should move the ruxolitinib front line, because in fact we know that the standard first-line treatment, and this is the EBMT recommendation, this is based on steroid, but we have around 50%, half of the patients that are going to fail on steroids are associated with high morbidity. So really need to improve this first-line treatment. And given the effectiveness of steroids as a second-line treatment, it seems very interesting to use it as a first-line treatment, or maybe combined with the lower doses of steroids. And we have some data that were already presented at the IACH meeting, in particular from a group from China, that show that the addition of ruxolitinib with lower doses, so 1 milligram per kilo of steroid was associated with a very good efficacy with less treatment failure. So yes, ruxolitinib may be promising as these first-line treatments, but the goal will be at the end to get rid of the steroids completely. It may not be completely achievable because we still need some small doses of steroid, but maybe in the future will be some very short treatment, 1 to 2 weeks of steroids, just to be effective, and after we'll just keep the ruxolitinib.
So something like an induction phase with
Yes.
high-dose steroids to calm the inflammatory process, and then give consolidation and maintenance with ruxo. That's interesting. Ali, what is your current practice, just to have an idea today? If you have an acute GVHD, how do you manage such patient?
So we go by standard. First line is corticosteroids, and in case of steroid refractory disease, we go by ruxolitinib. And then when it doesn't work, it becomes more complicated.
So can I ask, and maybe, I don't know, Bipin, you can jump in, because during this 50th anniversary of the EBMT, we also celebrated the 30th anniversary of using ECP in GVHD. So Bipin, what are your thoughts today about the use of ECP earlier for GVHD, including in acute GVHD, actually?
So it's rarely used nowadays. We used to be a huge ECP centers in the country, in the world before. You can look at the publication from Vanderbilt. Dr. Jagasia was our GVHD leader. But since we have a steroid-sparing agent and early institution of those steroid-sparing agent, utilization is very low. So I'll give you one example last week only. So we had one patient, PTCY-based heparin transplant for myelofibrosis. He's around day 43 post-transplant. Day 38, he developed severe skin rash, 70%. Started on steroid, but we started with 0.5 mg per kilogram. 5 days later, we added Rux to help with the steroid taper. And our plan was, if he's not getting better, to consider ECP in acute GVHD. Very rarely used nowadays for chronic GVHD. But yeah, it's used when we have a first line failure, second line failure, and now we have a third line belumosudil in certain GVHD condition.
Well, we'll talk about chronic GVHD, but first I'd like to have your opinion, Arnon, because it was mentioned by Zina, by Florent, about this new era, I would say new frontier, which is about the microbiota modulation. Obviously, we're talking about a salvage treatment for acute GVHD, for ruxo and steroid refractory acute GVHD. But if you listen carefully to the presentation at the opening lecture, the role goes beyond, because manipulation of the microbiota would allow to avoid bacterial resistance, maybe can decrease the incidence of relapse, but also improve the overall outcome through different parameters. So any thoughts on this, Arnon?
So, because I'm not in my first year in transplant, to see, first of all, what is happening now in GVHD, which is the main obstacle for successful transplant, and for sure for transplant-related mortality, is fascinating. So we can discuss, and we have so many new effective drugs, and we even dare to discuss, putting, maybe omitting or reducing the dose of steroid up front is, for me, almost a dream. This is number one. Number two, as you are doing in myeloma and perifacon, steroids is the number one killer or problem in post-transplant in the post-transplant weeks and months. And if we could get rid of the steroid, this would be, a major, I would say, breakthrough in transplantation, and maybe open the field of transplant to, even other things that we are not daring to do today because of the high mortality. Florent, show very nice data about, organ specificity of the extracorporeal plasmapheresis, ECP. And I think that part of it is depend on what organ you are talking about, but, if it's skin, it's mucosa, something very difficult is the liver, GI tract, or the lung. But for the microbiota, it's really fascinating. The data, I could never believe, the response that you have for GI tract, fecal transplantation, and so efficient and so fast. So really, it's amazing. It's really, for me, still hard to believe, but these are the facts for not just from studies that Florent present, but also Marcel and many other. And I think that there is a whole board there, a whole future there, and we are just in the beginning. So like the haplo, we are now dissecting per organ, the GVH per organ, the conditioning per organ. We will have, after we show, and all the world will believe in this data, because it was at the beginning, there were some skeptical people saying, here microbiota affect everything, from gynecology to cardiology to brain to everything, and we're laughing. Now that we start to believe, or everybody will believe this data, I think that we will manipulate, and fine-tune the microbiota, as you say, for maybe reducing relapse rate and the specific according to the bacteria, the positive, the negative, depleting, enriching, like we spoke about graft manipulation with ORCA.
Thank you, Arnon. So Florent, everybody is mentioning your talk, and actually the slides were shown several times on social media. So can you give us a brief summary about this study? Because obviously not everybody in the audience was attending EBMT.
Yeah, so thank you, Mohamad. So in my slide, I give the result from the compassionate use program using the microbiotherapy product March 13. So 140 patients were treated and presented. So this is a big number of patients. So it was some patients with steroid resistance and also resistant to other treatment, because in fact the patient received a median of 2 previous line of treatments, and 49 patients also received ruxolitinib right before the March 13. So they received steroids, ruxolitinib, and right after the March 13 for 49 of the patients. For the entire cohort, we have an overall response rate in the gut of 52%, but we also have some skin involvement for a quarter of the patient, and we also see responses in the skin and also in the liver for some of the patients. So we have a broad efficacy, not only in the GI, and in the responding patient, it translates into an overall survival at 1 year of 68%. If we focus in the subgroups of 49 patients that received steroid first line, ruxolitinib second line, and then the microbiotherapy March 13, the response rate are even higher, being 63% for the GI overall response rate, 61% if we include also the skin and liver involvement, and most importantly, it was some sustained response since at day 56, the response rate remained at 53%. So we lose some response, but not that much compared to other treatment where we lose a lot of responses between day 28 and day 56. And also in this subgroup of patients, the overall response rate for the 49 patients was 49%. If we compare from some historical data of steroid and ruxol-resistant patients, it was expected to be around 50%, so it's a big improvement. And in the responding patients, it reached 76% of the patients that are alive at 1 year.
Wonderful. Thank you very much, and congratulations, Florent, and obviously showing such amazing data in a population where you have patients who didn't respond to steroids and to ruxolitinib, but also other lines, and showing such a high response rate, including CR and VGPR. is definitely a big advance. So let me move now, guys, to chronic GVHD, because that was also another highlight. But before talking about drugs, I was personally very moved because I chaired one of the patient advocacy sessions, and EBMT has this particular track dedicated to patient, and this is quite unique. And I know there are patients also attending and following the IACH activities, and we are very proud that we have launched a couple of months ago a special series of webinars called the IACH for Patient. So I would like, before talking about the management of chronic GVHD, that someone, maybe Ali or Bipin or Zina, whoever want to jump in, remind us the deleterious impact of chronic GVHD on the quality of life of the patient. And obviously these days, the goal is not anymore just to be alive without leukemia. The idea is to be able to live long and well. And this is the idea behind now all of these new endpoints of graft versus host disease and failure and relapse free survival, incorporating all of these endpoints. Maybe Zina, you would like to comment on this?
Sure, thank you. I mean, Mohamad, for mentioning this. It's so wonderful. We also, in the Transplant Complications Working Party, well, maybe not everybody have seen it, but we actually included also a patient representative from the US. Bipin will probably know Meredith Coden, who has actually helped form the GVHD Alliance. So she's done, I think, 3 years great effort for patients in the US, and we are trying to duplicate something like this in Europe. So I hope we can do it also with the help of EBMT. So fingers crossed for that. So really thankful, Mohamad, that you are mentioning this, because really even all the guidelines that we have done recently, so for lung GVHD, all the guidelines that we are doing in the last times, we are including a patient representative. So really this has to be moved to, because with all the drugs that we have today, this is what at the end matters. If we have similar outcomes, the thing that will matter in the future is what actually helps patients the most. So also, if you see the data from the updated data from the belumosudil study, from the axatilimab study as well, you will see that all these studies now include patient-reported outcomes. So in the belumosudil study, the efficacy at 3 years is good. It's like 70% or more as it was at 1 year. But what is also important, that the Lee scale, so the patient-reported range of symptoms, is also very good, around 60%. So this is something that really matters. There's no study today that reports only clinician-assessed outcomes, because we know actually that the clinician-assessed outcomes are sometimes better than the patient-reported ones. Also, one other thing that I would like to mention, that is the great effort that is also being done, and that's also I think done also by the FDA as well, and that is the patient-reported adverse events. So the CTCA, actually, patient-reported adverse events, because again, what we tend to do as clinicians is, let's say, underrate the side effects that our patients have, and there has been really a great effort that is being done in addressing adverse events by patient, and by doing that in the right way by CTCA, actually, as it is. So this will be, I think, implemented in all future studies, in all future efforts, because I think now we are very well aware that we cannot move on in evaluating drugs or any treatments without including patients. So I think Bipin can probably add on something more, because this effort has been a lot maybe done in the US. So we are trying to duplicate what is being done there. So I think maybe Bipin could be a great person to comment.
Thank you, Zina. I agree with you. And PRO, patient-reported outcomes, is gaining popularity. Very important. But I just wanted to highlight also that what we have seen late effect in the past, and we are still seeing, and will continue to see, is based mostly on match-related donor transplant, match-unrelated donor transplantation, with now 60 to 80% of the patient receiving haploidentical transplant, PTCY-based haplotransplant. So those common transplant procedures are declining. Now, based on my summary on history of chronic GVHD or incidence of chronic GVHD on most publication, all highlighted their haplo-related GVHD is lower and lower and lower. So in the future, 5 years from now, 10 years from now, we will still see whatever we are publishing right now, GVHD-related psychosocial issues, quality of life, financial issues, many things. But we may be seeing less those issues, and maybe we will be seeing some other late effect of PTCY-based haploidentical regimen in the long term. We don't have enough data. So still, we are talking about GVHD-related. Maybe I'm expecting, based on what most patients are off immunosuppression by 12 months, less longer chronic GVHD. So we will probably see less and less those issues, and maybe see some different late effect in those populations.
So before going into the novel drugs in chronic GVHD, and because we're focusing on the impact on patient, I would like to maybe distract you a little bit, because CAR T cells are also an incredible tool towards improving not only the outcome of the disease, but also because it's a single shot treatment, then patient can enjoy, even if they are still in a chronic condition, a long period of treatment-free interval, and then can enjoy some form of normal life. So maybe, Ali, I can kindly ask you to comment, because obviously in lymphoma, but also in myeloma now, we have rapidly growing indications of CAR T cells. If you can comment on the importance of having like a single shot treatment done and then wait and watch, compared, to all of these cumulative treatments over time, whether in lymphoma, in myeloma, or leukemia.
So definitely, I think that this is one of the main reasons for the success of CAR T cells, and patients actually love this idea of getting a single treatment and being then off therapy for a while, sometimes for years, and sometimes cured. Even though and we have to talk a little bit about pharmacoeconomic, even though we can consider that the treatment itself may be quite expensive in the beginning and may not be affordable by healthcare systems in less privileged countries. But if you calculate well, for example, now we have bispecific antibodies that have a kind of similar mechanism of action to CAR T cells. If you calculate the cost of a continuous treatment with bispecific antibodies, at the end of the day, you may end up paying more. So I think that this treatment is associated with a significant improvement in quality of life of patients. And you mentioned the use of CAR T cells in chronic GVHD. I think that there are very exciting data about the use of CAR T cells in autoimmune disorders. So this can extend the field of cellular therapy to SLE and multiple autoimmune diseases.
No, this is really fantastic, and we can spend hours about all of these fantastic, futuristic. It looks like science fiction, but it's already there. We have a publication in the New England Journal of Medicine about refractory lupus beautifully responding to anti-CD19 CAR T cells. So maybe, Florent, you can comment now on the novel treatments and the treatment algorithm for obviously the most advanced chronic GVHD, because again, I think we're still a little bit stuck with this 1 milligram per kilo of steroids in the beginning. Then Ruxo has been approved and validated thanks to the REACH3 trial, but now we have other options. Maybe you can say a word about this.
Yeah, thank you, Mohamad. And in fact, for years or decades, we don't have any effective treatment besides steroids for chronic graft-versus-host disease. Now we have the approval of ruxolitinib for the second-line treatment, or we have some more treatment available in case of ruxo refractory patients. In particular, we have the belumosudil that have been approved by the FDA, that is not approved yet in Europe, that can be used in some countries through some early access programs that show some very good results. And it was highlighted by Zina in the first comment that we have also the update of the belumosudil study that were presented during the EBMT that confirmed that this is a very, very effective and promising treatment in patients that are refractory to steroids or ruxolitinib or other line of treatment, and that is a very good option as a third line of treatments. We also have the axatilimab, the IACH clinical trial that was presented as at the oral plenary session at the ASH that have been also updated. That is also a very promising treatment that is not accessible in most countries, but we see that in the 1 or 2 years coming that we'll have a lot of changes and a lot of new options to treat chronic graft-versus-host disease. What would be great, my last comment, if we can move one of these drugs in the frontline setting combined with steroids to be able to get rid of the steroids, but we'll see what the future tells us about that.
But I think because the information is available, we can also say that belumosudil is being now or will be tested in the near future in the frontline setting, which is definitely good news. And hopefully, if we are able to get a totally different philosophy, trying from the beginning to avoid the concept or the notion of refractory GVHD, whether acute or chronic, this is when probably we're going to win. Ali, you wanted to comment on this?
Yes, I wanted to have the thought of the colleagues about one aspect of chronic GVHD that affects significantly the quality of life of patient, which is chronic GVHD of the eye. It is a rare complication, but frequently does not respond to topical treatment and does not respond to systemic treatment in many patients. So any thoughts about novel therapies for this niche indication?
Zina?
Well, thank you. It's a great question. Actually, one of the forms of GVHD that impairs quality of life the most, because if you cannot see what, of course, it is horrible, and we know that it can progress to ruptures, and then this can be really debilitating. So this really is a huge problem, and the problem is that really systemic treatment doesn't work best actually in IGVHD. But actually, there are local treatments that in Zagreb we had some experience with amniotic membrane transplantation. So some of the innovative treatments that is actually used in ophthalmology to then be used in GVHD of the eye, it seemed to work very, very well, because it's something that can be used without immunosuppression. It has been used in Stevens-Johnson syndrome, and it seems to have some prolonged immunosuppressive effect, probably. So, and it also works as a physical barrier. So, but the point what I wanted to highlight here is that we came to this treatment by having a multidisciplinary team for chronic GVHD, so including other specialties, because chronic GVHD cannot be managed by only a hematologist, unfortunately, unlike acute GVHD, where I think we cannot be surprised easily. But in chronic GVHD, as so many organs are involved, we really cannot be the best chronic GVHD experts on our own. So we have to have, so in chronic GVHD, the crucial thing is to have a multidisciplinary approach, and that kind of approach then improves the management, including brings new treatments, because these are the things that only ophthalmologists could remember that we could use, of course, because this is something that they use frequently in their practice, and we could have not imagined to use it in chronic GVHD of the eye if we didn't have a dedicated ophthalmologist in the team. So I think crucial for new and I think in chronic GVHD local management, there's still improvement for local, as well as in, let's say, tissue repair in acute GVHD. I would say local repair in chronic GVHD can be improved as well. But I think only through multidisciplinary management and including other specialists.
Bipin, you wanted to comment on this?
Yeah. So not only ocular, but if you look at the difficult to treat chronic GVHD, the joint, fascia, lungs, ocular fibrosis, like we already discussed. And if you look at the belumosudil data, they have a 70% of the patients were difficult to treat GVHD, including ocular fibrosis, 78%. And they responded well. This is what just wanted to highlight.
Excellent.
That's
Arnon?
encouraging.
I mean, I just wanted to mention the velomosudil, but Bipin did it. But I have a question, if I may, about abatacept. So we are not using it in Europe, but in the States, it's making a big difference in mileage, and even we all know this paper from the NMDP about mismatched transplant becoming like matched transplant, 7 out of 8 to 8 out of 8. And the data about combining abatacept to PTCY, we heard it at ASH, and now there are more data. So, Bipin, maybe you can, introduce us and let us know what is the importance and what is the situation of abatacept in Europe or the States. Thank you.
So I think, Arnon, you are alluding to the combination of abatacept with post-Cy, which was published by a group in New York. And indeed, it can provide a good alternative. And actually, it was approved based on registry data. And I believe we had a couple of cases where we couldn't deliver post-Cy for whatever reason, and abatacept proved to be of importance. Obviously, I don't know what the future will look like, but anyone, Bipin, you want to comment on this?
There were some abstracts also in the EBMT, and combination. Yeah,
So, what I know from the utilization in adult.
No, we lost you, Bipin. Just reconnect.
Oh, yeah. I'm sorry, I pressed agree. So what I know for utilization of abatacept in adult hematological malignancy is very, very minimal. This is my personal opinion based on what I know the data.
Okay.
It's used mainly for the benign people have used in benign condition a lot.
Excellent. So for the last 10 minutes of this webinar, I would like to focus on CAR T cells and maybe ask about some highlights. Obviously, you have already mentioned the futuristic maybe use in autoimmune diseases on a wide scale, including chronic GVHD. Why not, I would say. We discussed also their huge impact, positive impact on the quality of life of patient, given the fact that this is a single shot treatment. So today, whether in ALL, for instance, or lymphoma, and I can discuss, say a word about myeloma, Arnon, in ALL, what are the current indications in your practice and based on EBMT for CAR T cells, the anti-CD19 CAR T cells?
So just a general word that the CAR T-cell CD19 are moving forward, not just CD19. So both for lymphoma, NLL, and myeloma, we heard in the IACH, we heard in the EBMT, the studies that show that if we move the CAR T-cells up front for high-risk lymphoma, we will talk about it, or for myeloma, after two lines of therapy, the results are even better and the patient benefit. For ALL, I think that, the CAR T-cell really doing, again, miracle. It's a word that I mentioned here a few times, but this is exciting area for me. And, we are having less and less transplant overall in ALL. The big leaders in ALL in Europe and in the States, in their recent data coming from Italy and from MD Anderson and even from Germany, they are transplanting only a limited number of adult patients with ALL, mainly according to mutation and high risk. The replacement is a bispecific antibody, mainly blinatumomab, moving very early. Maybe people are even talking about blina upfront and blina to MRD negative patients, and also inotuzumab, and even in patients that are MRD positive, some of the centers like MD Anderson are using CAR T-cell and not allogeneic transplant. So I think that CAR T-cell made the revolution in immunotherapy and CAR T-cell in adult ALL. And then we still have a debate about yes or no to transplant post-CAR T-cell. This is an open question. But I must say that even here, compared to 2-3 years ago, there is less people that are doing allogeneic transplant using the CAR T-cells as a window. The data of yes for allogeneic transplant are mainly from China. Very impressive data. Huge number of patients. They are showing even in MRD negative post-CAR T-cells the advantage of allo transplant and haploidentical transplant. But I must say that in Europe, in the Western Hemisphere, less and less centers are doing allo after CAR T-cells. So I think that I don't know if to say that CAR T-cell cure ALL, we need longer data, and we still are talking about 40-50% of long term, but really a breakthrough here.
Thank you, Arnon, and I would say it's work in progress, but it's quite amazing to see what we have seen recently in B-ALL and even in Philadelphia positive B-ALL with the TK inhibitors, blinatumomab, inotuzumab, and of course the classical chemo.
One word I forgot, you mentioned the beginning, even in TLL, we have now CD5 CAR, CD7 CAR. There is beautiful data from China. You do the CAR as conditioning, and then come allogeneic transplant with no GVHD, prophylaxis, no conditioning, and cure the patient. So really fascinating data. Still, clinical trials also in TLL.
Wonderful, thank you. One last question to you, Ali, before concluding with the whole panelists. And I think it is a relevant question to all our colleagues practicing in low and middle income countries who may not be able to afford, at least at this stage, the commercial CAR T cells, about the indications of auto versus CAR T cell in relapse in lymphoma. What can we say about this topic? Because obviously auto transplant is widely available, popular, cost-effective, affordable, and safe. So what can we say about this?
Okay, thank you, Mohamad. This is a very important question. So actually in lymphoma, we have to go by histology, and I would mostly focus on a large cell lymphoma. As you know, CAR T cell is able to cure around 40% of relapse refractory at late stage of large cell lymphoma, and recent data have established CAR T cell as second-line treatment for early relapse, less than 12 months, superior to auto transplant. But I think that the question was not asked well, and we have in these randomized trials, and we have very important data from the CIBMTR that were presented at IACH as well as published in Blood, showing that if you do salvage therapy and if you achieve PR or CR after salvage therapy, even in early relapse, then auto-transplant is superior to CAR T cell. So this may be a strategy, particularly for middle-income countries in which auto-transplant is well established and available, whereas CAR T cells are either not available or available at a minimum possibility, is to adopt this strategy of salvage therapy, then doing the CAR for patients who don't respond and going for auto-transplant for patients who respond. And actually, at EBMT, there were also very exciting data about the use of CAR T cell in primary and secondary CNS lymphoma, which is also an unmet need in the lymphoma field. And as Arnon mentioned about allotransplant, now we have data about what to do for patients who relapse after transplant. After CAR T cell, sorry. And actually, it seems that there are two well-effective strategies using CAR T cells other than CD19, so other types of CAR T cells for patients who relapse after CD19 CAR, and using allotransplant after relapse after CAR T cell seems to be one of the most effective strategies.
This is incredible because it looks like in AML, now we're just pushing the indications into the most advanced stages. And actually, it's always good to see these innovations. So we have reached the end of this post-EBMT summary. I'm very grateful to all of you guys. You've done a wonderful job because in 75 minutes or so, you gave us the best of EBMT, going from conditioning, and we just concluded maybe by using allo as a salvage post-relapse after CAR in lymphoma, but also some future perspective regarding immune therapies and different indications. Management of GVHD is definitely moving positively in the right direction, whether acute or chronic. Thank you all for joining us. I hope you have enjoyed this summary. Apologies, we couldn't take all the questions, but I believe you had some of the answers during the discussion, and you can always reach out to the panelists. Of course, like every IACH activity, this webinar will be available on demand in a few hours on the Academy website. So thanks to the faculty, thanks to all of you, and I hope we'll catch up with you very soon in another IACH activity. This is the IACH around the globe and across the hematology field. Take care.
Thank you.
Thank you. Bye. Bye.
Bye.